Good afternoon, everybody. I would like to acknowledge that this land we meet, work, live, and play is on a traditional land of the Ghana people, and we respect their spiritual relationship with this country. We pay our respects to their leader, past, present, and emerging, and acknowledge that their language, cultural, and traditional beliefs held for over 60,000 years are still as important and relevant to the living Ghana and all Aboriginal people today. We have two exciting speakers today, and it's my pleasure to first introduce Stuart Callary, who is a senior medical scientist in the Department of Orthopaedics at the Royal Adelaide Hospital and the University of Adelaide. He has been a leader in all aspects of musculoskeletal imaging within our team. For the last 2 years, Stuart was the Mary Overton Research Fellow funded by the Royal Adelaide Hospital Research Fund. This year, Stuart began a new research fellowship from the Hospital Research Foundation with an overarching aim of improving outcomes of patients undergoing total hip replacement surgery, which he will discuss today. Stuart.
Okay, thanks, Bogdan. Just bring my slides up. Thanks for the kind introduction. As Bogdan mentioned, I'll be presenting some of our research that we've conducted over a number of years with the aim of improving the outcomes of patients following total hip replacement surgery. At the RAH, we have a unique multidisciplinary approach, and just an example of this is our weekly department grand round and clinical team meetings held every Wednesday morning, where surgeons, trainees, interns, medical students, other specialists, allied health, theatre staff, and our safety, quality assurance and research unit all attend. And this meeting briefly aids in the planning of surgical treatment for the individual, but also a guide for protocols within the hospital. It enables teaching and training, and of course these meetings, they really enhance the cross collaboration of knowledge and ideas, not only on clinical knowledge, but research ideas as well within the team. So one of the benefits of our team, our safety, quality assurance and research unit, has been the establishment of a hospital-based registry for all orthopaedic admissions from 1990 onwards. And in particular, we've focused on all arthroplasty cases, their surgical details, their patient-reported outcomes at each follow-up time point, and matched radiographs that have been kept for every individual at each follow-up. And this allows us to summarise all of the complications for cases treated at the RAH at our 3 monthly audits. And the most common reasons that total hip replacements fail are for implant loosening, dislocation, and infection. And this auditing done as part of our quality assurance team leads into research projects. For example, this is an example of a large retrospective review of over 2,000 primary total hips that were performed over 15 years at the RAH. And we searched all of our documentation and database for any patients that had had a femoral periprosthetic fracture following primary total hip. And if we were relying on national registry data, we would have only identified the 9 patients that were revised for fracture. And we were able to actually identify 47 patients that had fractured their femur and were treated with open reduction internal fixation. So this has a unique capability of capturing data that isn't routinely collected in national registries, but it also allows us to go back through the data, and we were able to identify that most of the primary patients that fractured post-op were treated, had a primary diagnosis of NOF or were secondary to trauma. More recently, our research has led us to capture a more comprehensive database of outcomes, and we've really tried to hone down on the most sensitive outcomes available for each of our studies. A lot of my work has been focused on radiostereometric analysis, which is a unique X-ray method of measuring implant stability. We capture bone biopsies from theatre, which Deepti will talk about in the second presentation. And we've got a long history of collecting patient-reported outcomes. We use CT, MRI, and normal X-rays. And perhaps more recently, we've started to follow up a lot of patients with gait and activity monitors with Associate Professor Don Phillis at the University of Adelaide. So my part of the musculoskeletal imaging has really relied heavily on RSA, and it's a prospective technique. And the unique thing is that it can only be done in centres that have the calibration cage and the specialised software, and it also relies on beads being implanted into the bone during the operation. And the unique thing is when we go to the resultant X-ray, we can measure the implant migration relative to the bone within 20 microns. And this has two main benefits. One is to reduce the sample size, almost up to 5 times less people are required in a cohort followed by RSA compared to plain films. And two, and this is the most important thing, the RSA measurements at 2 years predict long-term implant success. So instead of following patients up for 10, 15, 20 years, you can measure their implant movement within the first 2 years and predict if the implant will be stable. And recently, with the European changes to the medical device regulation, each company now that introduces a new implant will require an ODET rating on this score. So you either get a score of 2, 5, 10, or greater than 10. And RSA studies provide the earliest surveillance of new implants at 2 years. So this is particularly important, and this change was only made in May last year. So I won't go into detail of all of the RSA studies we've conducted over the year, but we do have a lot of clinical trials. They're in 3 main areas. Our primary hip studies are usually randomized trials looking at different new implants used. Our revision studies looking at the best surgical technique available and assessing the implant migration following. And our fracture studies have looked at fracture movement not only over time, but under load, and assess weight-bearing protocols. More recently, our research is focused on revision, and this is because 36% of revisions will require further surgery within 10 years, which is an unacceptable result at the moment. This is because they're more complex. You're dealing with large bone defects. These patients require a longer length of stay, and the treatment requires specific clinical expertise. And it's often not widely acknowledged because the primary the workload within Australia, 92% of the workload of all arthroplasty cases are primary hips, and only 8% are revisions. But the RAH, being a tertiary referral centre and with a catchment area of everywhere north of Adelaide up to Darwin, we see our workload for revision hips is up to 45%. So we're in a unique position that we can follow these. We have a lot of these cases come through, and we can follow them up for a long time. This graph just shows one series of patients of the acetabular cup migration over time of cases that were treated between 2003 and 2012. And the cases in red moved significantly above our established thresholds and were later revised. And compared to more recent cases where additional inferior fixation was used between 2012 and 2016, you can see all of the cases are within the grey threshold bar. So this is really encouraging for further use. So if you actually look at the literature, we are the first centre to monitor surgical changes over time using RSA, and this is the largest cohort available of these revision procedures with the longest follow-up. So it's quite a unique series, and we're continuing to prospectively collect revision patients as they come through the RAH. So all of this research has now led to my new research theme is, can we improve the early surveillance of new implants? And one way that we can do this is to fast track the evidence by validating a preclinical testing method. And we're using our unique combination of outcomes that we've collected on a number of patients, including gait and CT. And what you can do is create a FE model from the pre-op CT. And FE models have been used in a number of studies, and you can virtually implant an acetabular component and predict how much it will move. But to date, they haven't been validated clinically. And these are just some of our most recent data of 8 patients. And this is the amount of movement that was predicted from the pre-op CT using the FE model for each case. And this is the latest data for the same 8 patients of the in vivo movement measured by RSA. And while there are too few numbers to make any huge claims yet, it is very encouraging that case 51 had the largest predicted motion and the largest in vivo migration measured by RSA. And conversely, 44 and 46 had the smallest predicted motion and were the most stable in vivo. So we're really excited by this, and we've already enrolled a number of patients to follow up. So in summary, I feel really fortunate to be part of the CALHN research environment, especially here at the RAH, in combination with the Centre of Orthopaedic Research at the University of Adelaide, because not only do we have experts in biology, biomechanics, CT and RSA imaging, but we're able to follow up patients in combination with their routine clinical appointments. And this gives us a unique advantage that we can follow these patients up for more than 20 years in some cases. And finally, I'd just like to acknowledge the RAH Research Fund, which funded my previous Minireview Fellowship, and the Hospital Research Foundation, who I'm funded by currently. Thanks, Bogdan.
Thank you, Stuart. I would like to invite people in the audience to ask questions through the question and answers button. Stuart, can you tell us where next? What are the next projects that you intend to run?
One of the areas that we've been working on for the last year is to not rely on RSA measurements. Not every centre can use RSA. They don't have a calibration cage. Surgeons aren't willing to put beads in interoperably. And what we're trying to do is develop a software method that can measure implant migration really accurately off of plain radiographs. We're doing this with the University of Adelaide ECMS guys. And to date, that's looking positive. We'll probably never achieve the same accuracy as RSA, but because plain films are more regularly available for the larger population, we should be able to do some really big studies and identify the outliers, and then try and work out why some implants do move, and why do people need to be revised for loosening later on.
Any developments in how you can better assess or fine-tune those FE models that you're talking about?
Well, we're in a fortunate position where we've got patient-matched data, not only the load through the hip from the biomechanics exam, but also the number of cycles that each patient is doing through the activity watch that they're wearing at various time points. And we're hoping this patient-specific matching of data for a larger cohort that we're currently enrolling patients into a trial for this. We're hoping that will iron out some of the bugs in the FE model and try and improve the predictions made in that FE model. So one area that it definitely needs to improve on is a greater appreciation for the poor bone quality of patients undergoing hip replacement, because previous FE studies just assume from global atlas data that the bone quality is quite good.
Thank you very much. I think there's no other questions, and I can't see any. We will move towards the second speaker, and it is my pleasure to introduce Deepti Sharma, who is a medical scientist within our team. Deepti has had a significant scientific career in industry prior to commencing a PhD in 2016 under the guidance of Howard Morris at the University of South Australia. She has a background in nutrition and bone health and is currently leading several clinical projects of hip arthroplasty patients will be described in a talk. We are very fortunate to have Deepti in our team, and it's my pleasure to ask her to present.
Thanks, Bogdan, for the kind introduction. Well, I would like to start by thanking the organizers to give me this opportunity to present some of the work I have been doing in the area of nutrition and bone health. Now, any aspect of nutrition or intervention on bone health can be measured by two broad parameters. One is bone mineral density, which measures the amount of mineral in the bone, and the second is the bone quality. Now, bone quality includes aspects of bone structure, microarchitecture, and bone turnover. In clinical settings, it is difficult to measure bone quality, and therefore the most widely measured outcome is bone mineral density. And therefore, most of the nutrition studies investigating the effect of any particular nutrient on bone have looked at bone mineral density as an outcome measure. And all these trials have resulted in a series of conflicting evidence, whereby while the population studies which look at fracture as an outcome show the beneficial effect of nutrient on bone health by showing a reduction in risk of fracture, but the supplementation studies which measure bone mineral density show null findings. And this led us to hypothesize that potentially most of the nutrients influence bone health by influencing the quality of the bone and through pathways which is independent of bone mineral density. And therefore, we believe that there is a requirement to undertake more mechanistic studies to demonstrate the role of nutrition on bone quality. And this will allow us to enable evidence-based practices, which can then translate into supplementation guidelines. And therefore, we at the Royal Adelaide Hospital are working towards developing an ortho-nutrition research theme. And this theme is based on a strong foundation, which was laid by leaders in the field of bone metabolism, such as Chris Nordin, who was a pioneer in calcium metabolism and studying the pathophysiology of bone loss. He established long-standing and successful collaboration within the Royal Adelaide Hospital with surgeons like Prof. Howie, and with biochemists such as Professor Howard Morris at SA Pathology, and many endocrinologists. And what this collaboration resulted in was a series of studies which generated data in Australian population and also in South Australian population, looking at the relationship between nutrition and bone health, in particular calcium. And most of the research findings have clinical importance, and they are informing management of patients even to date. I was fortunate enough to join this group in 2016 and had the privilege to investigate mechanisms by which vitamin D influence bone quality and therefore result in fracture risk reduction. And since then, I have built onto these research areas by adding newer nutrients such as vitamin K, which I will be describing in my presentation today, and also looking at some allied pathways by which nutrition can influence bone, such as by modulating gut microbiome. Now, what puts me in a unique position to undertake these research area is my employment with Royal Adelaide Hospital, because I can collaborate successfully with clinicians and orthopedic surgeons, and therefore can translate all the research finding into clinical outcomes. Secondly, under the leadership of Professor Solomon, the surgeons at the Royal Adelaide Hospital have developed a suitable technique to retrieve bone biopsies, which are a very important biological material from patients who are undergoing elective hip replacement surgeries and who are being treated for hip fractures. Generally, these bone biopsies are a part of the bone is removed when the prosthesis is placed in, and so therefore in general circumstances these bone would be discarded. But the team here have devised some techniques to retrieve these biopsies intact from patients, and therefore there are very important clinical material which can help us to investigate structural properties, including bone quality, which cannot be measured in clinical settings. I will start by sharing some of the results of my vitamin D study. Using these valuable bone biopsies and blood specimens that we retrieved from patients who presented for elective hip replacement and also for treatment of hip fracture at the Royal Adelaide Hospital, we demonstrated that vitamin D levels are not associated with any aspect of bone volume, as you can see from this graph clearly. However, what was interesting was that vitamin D significantly correlated with aspects of bone quality. And one particular measure which was influenced most was the bone surface to bone volume ratio. This parameter, bone surface to bone volume ratio, is an integrated measure of trabecular thickness of the bone and also the texture of the bone. What I mean by that is, I've got a visual representation to explain what I mean by thickness and texture. So this is 2 biopsies from aged and gender matched patients. As you can see, both the patients had similar bone volume. The image on the left is from a hip osteoarthritis patient, and on the right is from a hip fracture patient. Both had similar BVTV values, which indicates bone volume. However, you can see that the configuration of the bone is very different. The hip fracture patient has more rod-like configuration with thinner bone structure, and the osteoarthritis patient has thicker bone structure, and this is displayed by the differences in values of trabecular thickness and bone surface to bone volume ratio. What was most remarkable was the vitamin D values in these 2 patients differed significantly. The hip fracture patient was deficient in vitamin D, while the osteoarthritis patient had sufficient vitamin D status. While this is just a representation of 2 patients, in this whole cohort of more than 100 patients, we were able to demonstrate using multiple linear regression analysis that vitamin D, along with vitamin D metabolizing genes, is an independent predictor of this bone surface to bone volume ratio, or an indicator of plate-like texture. And then we undertook a series of gene expression and histomorphometric analysis to understand what is the relationship between vitamin D and this plate-like configuration. And all these data put together help us to propose a mechanistic pathway whereby adequate vitamin D status, which is defined by levels more than 60 nanomoles per liter, results in the osteoblast or the bone forming cells to work for longer, which then results in plate-like trabecular structure, which can then potentially result in reduced fracture risk. And in the whole cohort, there was no relationship between vitamin D level and any aspect of bone volume. And this corroborates to the clinical finding, which shows anti-fracture efficacy of vitamin D without any changes in bone mineral density. We are now taking this work forward and investigating another important nutrient, which is vitamin K, and looking at the pathways by which vitamin K can influence bone health. Before I get into what we are doing in this study, I'll briefly explain about vitamin K and the background. Vitamin K is mainly recognized as a coagulation nutrient. However, the coagulation function is limited to one form of vitamin K, which is K1. There is another form of vitamin K called K2, which is present in some fermented product and animal products, which results in activation of an important protein called osteocalcin. This is a protein which is responsible for mineralization of the bone matrix. And studies have shown that lack of vitamin K2 can result in insufficient carboxylation of osteocalcin, and higher levels of undercarboxylated osteocalcin are associated with higher risk of fractures. However, supplementation studies, either with K1 or K2, show no relationship between the better carboxylation of osteocalcin and bone mineral density. So while the carboxylation status does improve, there is no change in BMD. So we are now undertaking this study to investigate the mechanistic pathway. And to do this, we have established a multidisciplinary team comprising of orthopedic surgeons, orthogeriatricians, scientists both at the Royal Adelaide Hospital and also Adelaide University, imaging specialists, and biochemists at SA Pathology. And what we are doing in this study is we are recruiting a cohort of elective patients who are undergoing elective surgery and also getting treated for hip fracture. And we will be retrieving bone biopsies from these patients, which will then undergo microarchitecture and gene expression analysis. In addition, we will also be retrieving blood specimens, and we are measuring not just vitamin K levels, but also K2, and there are various subtypes of K2. So we are measuring K24 and K27. Basically, this number indicates the number of side chains. And there is no assay currently in Australia which can measure K2 levels accurately in blood. And because of our collaboration with assay pathology, biochemists at assay pathologists, we are able to set up an assay system that can accurately measure these metabolites along with carboxylated osteocalcin and undercarboxylated osteocalcin and several bone turnover markers. In addition, we will also be doing DEXA assessment in these patients. And we are very fortunate to have an in-house imaging specialist, Chris Schultz, who is a well-known bone densitometry expert. With his help, we will be using some advanced hip software to look at bone geometry, which is a surrogate of bone strength in these patients. And because of the presence of orthogeriatricians in the team, we will be able to collect a series of patient demographic and confounding factors such as physical activity, which can also independently influence bone quality. By collecting this whole host of data, we will be able to accurately determine the role of vitamin K on bone quality and potentially identify some of the pathways. And all this data will result in generation of first evidence of vitamin K1 and K2 levels in Australian populations, and also will provide the first tissue level evidence between the relationship of vitamin K1, K2 and bone quality. And this has not been investigated before. The next research theme, which we have just started to work on, is the relationship between gut-bone axis. And at the Royal Adelaide Hospital, we've been fortunate to establish a collaboration with Center of Excellence for Clinical Microbiome Research in India. And with their help, we are now trying to investigate if gut dysbiosis is a broad term which refers to presence of more pathogenic bacteria in the gut, if that gut dysbiosis condition is associated with compromised bone health. And in the shorter term, we would be looking at relationship between gut dysbiosis and bone quality. And we will also be investigating the relationship between gut microflora and incidence of osteoarthritis. Fortunately, we are able to add these additional aims to our existing vitamin K study. Because of our being located in the hospital, we are able to collect stool specimens from patients post-operatively before they are discharged. And analysis of stool specimens can give us an idea about their gut health, which will then allow us to investigate this aim. In the medium term, we are interested in investigating the relationship between gut dysbiosis and prosthetic joint infection. Now, prosthetic joint infection is one of the most devastating complications of arthroplasty surgery, and its prevalence is incidence in Australian population is around 1.7%. This is the only complication which is actually increasing, and therefore, a lot of efforts are being directed towards understanding the pathophysiology of this disease. While there is no clinical evidence to show a relationship between gut dysbiosis and PGI, in an animal model, which is representative of clinical PGI, it was shown that animals who had compromised gut microflora prior to surgery were 50% more susceptible to developing PGI after surgery. And so we will be recruiting a cohort of PGI patients and looking at their gut health. And then in the longer term, we intend to recruit some of these patients and supplement them with either good microorganisms such as probiotic or prebiotic, which can alter the gut microflora through fermentation. And then look at if supplementation with these beneficial microorganisms can reduce the incidence of PGI, improve surgery outcomes, and reduce the risk of re-revisions. We've applied for additional fundings to undertake these research areas. I hope I've been able to provide a brief overview of the ortho-nutrition research theme that we are investigating at the Royal Adelaide Hospital. And that's all from my side. I'll now hand over to Prof. Solomon. Thank you.
Thank you, Deepti. If the audience has any questions, please put them through the Q&A. Could you elaborate a little bit about how the collaboration with the All Indian Medical Institute will work?
Yes. So what we are hoping to do is either get some of the experts from their team to Australia, who can then help us to analyze the stool specimens, so extract DNA out of it, and then characterize the functionality and the kind of microorganisms in the patient samples that we have collected. Alternatively, we will also explore the possibility of sending these samples across to India and getting them tested there. Now, this group has already done a lot of research in the area of knee osteoarthritis, and they have shown that there are certain gut microflora which are associated with higher prevalence of osteoarthritis. They have not investigated hip osteoarthritis as of now, and which is why this makes this collaboration mutually beneficial, because it is an area of interest for them as well. In addition, in the PGI study, when we begin that, we will also be collecting whole blood specimens, and we will look at blood microbiome, which we are not currently doing in our current study. And that will give us an indication of not just gut microflora, but also blood microbiome. And together, this data can help us to characterize the gut health in this patient. And the data that we generate from the vitamin K study will help us to generate some control data as to how general gut health in orthopedic patients is.
Thank you very much. Well, if there's no other questions, we, I believe, running a little bit out over time, I would like to thank both speakers for their excellent talks and close the session. Thank you.